All right, we're recording. Stay if you want to be recorded. Okay. All right, well, welcome to May 8th, N3C Community Forum. Next slide, please. We've got a couple of interesting talks. As always, use the Q&A button and chat to communicate and raise questions. And we always like that. Next slide, please. So we're up to 7.5 million records of COVID positive cases, 1.9 million people overall. Next slide, please. And coming up May 22nd, so we're in an every other week cadence, as you guys know. Oral health team, domain team updates by Chen Liang and Yi Lin, and Enclave publication intent forms by Kate Bradwell, and June 12th protocol pad by Kate Bradwell. Next slide, please. So the two presentations today, Jared Anzalone will be talking about temporal trends in rural urban COVID-19 therapies and outcomes from Alpha to Omicron. So basically differences in how rural urban differences and how COVID has been treated and outcomes as the virus is evolved. So that should be actually quite a complicated and interesting analysis. I'll be interested to see what they've come up with. And then a sneak peek researcher's guide to the N3C, led by Sean with a great team. And we're going to hear about what's going on with that. So Jared, I think it's yours, and can you share your slides?
Yep. All right. Yeah. Great. Yeah. Thank you so much for having me. Do you see the presenter view or the?
Let me see the presenter view. Oh, okay. Now
Let me fix that. It looks like I got to reverse it. You still see the presenter view, or is
it? That's nice. That's great.
Slides. Okay, great. Thank you.
Okay, thanks.
All right. Yes, I am Jared, and yeah, we're here to talk about some findings from the rural health domain team. And here's the project team. We'll just be covering, background methods, results, findings, and some interpretation of those findings. And for those of you who don't know, the rural health domain team is one of the many N3C domain teams that seeks to understand the epidemiology, utilization, treatment, and outcomes of the COVID-19 pandemic, focusing on rural communities. We meet monthly on Mondays, the first Monday of the month. And if you are interested in learning more, please reach out. So this project builds on two previous projects that have come out of the rural health domain team. The first project focused on higher hospitalization and mortality rates among rural dwellers, and that looked at differences in hospitalization and inpatient mortality among rural dwellers presenting at N3C participating sites after adjusting for baseline risk and comorbidities. The second paper looked at community risks for breakthrough infection among patients that were fully vaccinated in N3C. We found that certain community factors were associated with greater community transmission, even after being fully vaccinated, and a lot of those risk factors happen to be associated with rural dwelling status. So what we know to date, we know that rural communities have fewer healthcare resources in general, including lower access to specialty care, longer distance to any care, lower COVID-19 testing rates, fewer options for outpatient therapies, and lower overall vaccination rates. After the initial urban wave hit the US, the rural death rate finally surpassed urban in December 2020 and haven't looked back since. So this is a chart that shows the cumulative death rate over time. The blue line is rural dwellers, the black line is urban dwellers. And so this has persisted across all the variant dominant periods since the rollout of vaccinations, and lower vaccination rates in rural communities seem to be exacerbating this discrepancy over time. So here we see a different view of that same difference in mortality. Caseload is the bar and case fatality is the line plot. We see that once that initial rural overtook urban case fatality, the relative difference, despite overall case fatality going down over time, the relative difference between urban and rural dwellers has persisted over time. And this is at the population level using reporting from the Johns Hopkins dashboard through the end of 2020. So we know that vaccination and better care has been a large contributor to the management of the COVID-19 pandemic over the last 2 years. And we also know that rural communities have much lower primary vaccination rates, booster vaccination rates, and the updated bivalent booster doses. Here we see the difference in urban and rural counties as reported by the CDC through March 15th, 2023. And unfortunately, the gap here appears to be widening rather than narrowing over time, which will be an important focal point for the long-term management of COVID-19 in rural jurisdictions. So what do we know? We know that vaccination and better care has been a contributor. I'm going the wrong way, sorry. What do we know? So this leads us to our current project. And some of our biggest lingering questions are whether this gap has changed over time after we adjust for baseline risk, and whether there has been differential delivery of the relative protection provided by COVID-19 vaccinations and advanced COVID-19 therapies over time. Given potential delays in care-seeking behavior, both questions continue to be relevant for ongoing risk mitigation and future disaster preparedness. So our primary objectives were to estimate differences in hospitalization and inpatient adverse events throughout the pandemic among rural and urban dwellers, and to quantify differences in treatment rates and their impact on mediating adverse events among those treated in large health centers in the US presenting via N3C. So the primary research hypothesis was that delayed access to care might indicate more severe presentation among rural versus urban dwellers in N3C sites, which could potentially result in lower effectiveness of the same treatments because the treatments are all very time sensitive. And now we'll move on to our methods. This was a level 3 project, so that means we had access to zip codes and non-shifted dates. The data was extracted on April 20th, 2023, and that was N3C release 120. And because we were primarily interested in looking at the impact of vaccination and therapies, our time period was looking at the initial infection documented for patients presenting in N3C between January 2021 and the end of December 2022. And our key exposures were rurality, the COVID-19 epoch, which we're considering as the period before Delta dominance, which is in the middle of June, Delta dominance, which runs through the middle of December 2021, and Omicron dominance, which is the time period since. Vaccination status, we looked at completion of a primary vaccination series and the completion of a primary plus an additional booster dose. for vaccination. And then we looked at specific COVID-19 therapies, remdesivir, dexamethasone, various monoclonal antibodies, Paxlovid, molnupiravir, and anticoagulants. And then we also adjusted our models based on demographics and comorbid burden. So all of the individual CCI categories from the Charlson Comorbidity Index: hypertension, obesity, substance use disorder, history of tobacco, and census region. And our primary outcomes were 14-day hospitalization after initial infection. And then among those hospitalized, we looked at 45-day all-cause inpatient mortality. Secondarily, we assessed inpatient acute kidney injury or dialysis, major adverse cardiovascular event, invasive mechanical ventilation or ECMO. And then among those who were ventilated during that COVID hospitalization, we assessed risk of inpatient death as well. And our statistical approach included survival curves that should be 45-day survival curves among those hospitalized for death, and associations between rurality, hospitalization, and inpatient adverse events while controlling for major risk factors using multivariable logistic regression for hospitalization, and among those hospitalized, Cox proportional hazards for time to event. And then to assess model robustness, we also did a secondary analysis using propensity score matching on data partner, race, ethnicity, sex, COVID-19 epoch, and then using nearest matching on age and composite Charlson Comorbidity Index. And we did this to check primarily the robustness of our primary findings and to control for the N3C data partner, since we know both the amount of rural patients at each site is very different, and the reporting at each site also differs. So that was one of our primary statistical tools. And we also utilized a data partner robustness matrix to restrict to sites that had minimum reporting requirements in the key domains used in this study. So that included conditions, drugs, date shifting, zip code, which not all N3C sites provide 5-digit zip codes, which is necessary for rurality, and then death, since that was our primary outcome. And this is our results. The cohorts included just over 3 million patients. 2.5 million were from urban areas, and the remaining 500,000 were from rural areas. We looked at a gradient rural indicator that included urban adjacent rural dwellers and non-urban adjacent rural dwellers. Among those, the hospitalization rate was around 10%. It was slightly higher in non-urban adjacent rural than the other distinctions. And then our matched cohort included nearly 1 million patients. And then this was the distribution of our actual cohort, and it's the percentage of the county infected as presenting in N3C. So you see here that we do have some hotspots where we have better representation, but on the whole, we do have a good sampling of the US population. For those in the Midwest, we see the population kind of dispersed along Interstate 80 and then highly centralized in parts of New England and Colorado. And then these are the treatments that we assessed over time. Let me see if I can get my highlighter to show up. So on the bottom here, we see the time. So it goes from January 2021 through the end of December 2022. And we see consistently Paxlovid going up over time, and it's still going up through the end of the reporting period for this study. Molnupiravir is less utilized, same with tocilizumab. Dexamethasone usage has gone down over time. We saw a pretty big peak in the Delta period, but on the whole, it has gone down, and then remdesivir has been pretty consistent throughout. And then we wanted to assess the difference in virality on how these were administered in N3C. And in terms of inpatient therapies, didn't see a lot of difference. However, for outpatient therapies, we do see Paxlovid being administered more in urban dwellers, which is not surprising given the physical distance between N3C data partners and many of the rural dwellers receiving care in N3C data partners. And then the next few slides are going to be our survival curves. The red line, that's urban dwellers. And then there's a gradient risk by degree of virality. So this is 45-day survival among those admitted. Rural, and this is across all time periods. This is rural, this is urban adjacent rural, and then non-urban adjacent rural. And then for our epochs, we see at the top here that similar to what's been reported in the literature and the CDC reporting, Omicron is less fatal, but there are considerably more cases. And then secondarily, the pre-Delta period is the next line we see here, and then the lowest survival probability is in the Delta period. And then interestingly, as we saw with the population level metrics earlier, stratifying our survival curves by period and rurality, we see that the relative distance between all three is similar across the three periods. So even though in general the trends are going towards better survival, the relative difference between rural and urban dwellers in N3C is similar to the population, and that relative risk has persisted over time. And now we're going to get into our model results. So this is our results over all time for hospitalization and then inpatient adverse events. We see here this is logistic regression for hospitalization. So we see higher odds of hospitalization for both urban adjacent and rural and non-urban adjacent rural dwellers. And we see a very big impact of vaccination on lowering odds of hospital admission for both rural and urban dwellers. The purple dots, those are models that are combined rural and urban. So this is where we're looking at the difference between rural dwelling status, and then the red is stratified into urban, or the blue is stratified into urban and the red is stratified into rural to see the relative difference between the two. So then again, we see that for rural dwellers, there's about a 6% higher odds of hospitalization. And then we see a much lower odds of hospitalization in the Omicron period. And those receiving primary or primary plus secondary or plus booster vaccinations prior to their COVID-19, they saw much lower odds of hospitalization. And this is our results for death. So we see an even larger, and these are Cox proportional hazards. We see a larger risk of inpatient death among rural dwellers, nearly 30% increase among those in urban adjacent, and a 35% increase in non-urban adjacent. And then we see a much larger risk in Delta and a lower risk in Omicron, and then similar findings with vaccination status. So this is among patients who were admitted, and vaccination status still is highly protective against adverse events. And then this is when we start to add in our therapies. So as background, Paxlovid, molnupiravir, which I'm probably saying wrong, and monoclonal therapies were prescribed in outpatient settings. Monoclonals were also prescribed in inpatient settings. And then the remainder were prescribed in inpatient settings for moderate COVID-19. We also assessed dexamethasone and tocilizumab among those who were ventilated to look at severe COVID. and potential differences between urban and rural dwellers in those settings. So for hospitalization, we did see a very big impact in terms of these outpatient COVID therapies. Paxlovid, all three significantly reduced odds of being hospitalized, as did vaccination. However, even after adding these into the models, we actually had the exact same odds of hospitalization as we saw in models without medications based on degree of virality. And then for death among those admitted, we see this is just all death with the 4 medication classes that we saw before, and then this is death among ventilated. So we noticed that there was a lot of confounding by indication when we added dexamethasone and tocilizumab in the models that were not strictly among those ventilated. So we decided to look among only those ventilated, and we see protection from dexamethasone in those models, although we do not see as any protection among dexamethasone administered patients in rural dwelling statuses, which differs from urban dwellers. So that is an important finding of this. And then we see a reduction with remdesivir, anticoagulants, and monoclonal therapies. And when we did propensity score matching, I'm not showing those here for time, we did find similar results as what we found here. So our interpretation of this is that, similar to our previous findings, hospitalization, death, and other adverse events were significantly higher among rural COVID-19 patients than their urban counterparts after adjusting for background risk, including COVID-19 therapies and variant dominant period. The COVID-19 therapies we observed here were generally either associated with the same or lower risk or odds of adverse events in rural versus urban dwellers, with the exception of ventilated patients and dexamethasone. This shows that therapies and vaccination are crucial in lowering the rural-urban gap in COVID-19 outcomes, but systemic issues also need to be considered when evaluating remediation efforts. And then, these findings highlight the long-term impact COVID-19 will have on rural communities. Finding that, rural dwellers are at an increased risk of needing dialysis, mechanical ventilation, and ECMO shows that they're likely to have long-term consequences such as post-traumatic stress disorder, depression, anxiety, and physical deconditioning. Survivors of these require intermediate and long-term support for rehabilitation and recovery, which may stress already burdened rehabilitation resources in rural areas. And then these are some of the challenges that we faced. On the left-hand side, we see challenges that we encountered in previous studies, which is the inability to assess severity at admission, or look at referral in or discharge information consistently. And this is largely a limitation of site differential reporting and the current penetration of the research informatics community into rural and urban communities. And then secondarily, which builds on that, we had an inability to look at outpatient medications that are delivered in the community because the majority of N3C data contributors don't link up with community partners or health information exchanges, so we have access to things that were administered or dispensed in the hospital. And then, the takeaway here is that, continued efforts are needed to mitigate the disparity between rural and urban dwellers, both for the current pandemic and for future health outcomes research. And then I'd like to again mention that the N3C Rural Health Domain Team meets monthly on Mondays. Our next meeting is on June 5th. We meet at 3 p.m. Eastern. And with that, I would like to thank all the people involved in this project, which includes the greater N3C community, the N3C Rural Health Domain Team, which is co-led by Will Beasley, Kim Murray, and Bill Hillegas. NIGMS, which funds a lot of our efforts, and the IDEA CTR group, which is led by Dr. Hodder and Sharon Patrick, who we'll be hearing from shortly, and then NCATS and Palantir for making this all possible. And with that, I don't know if we have time for questions because I know we're about at the end, but yeah,
I think we've got a few minutes. So thanks. Great talk. Questions? So I have a question, or a type of question. So, okay, so it's very interesting documentation of these differences, rural, urban differences. And obviously, and you'd alluded to this, you've got the whole issue of rural urban differences in terms of care seeking and who actually shows up to the hospital. And are there any regions? I imagine there must be some parts of the country or some states where there's been a population-based survey of who's actually gotten sick from COVID-19, or maybe not. I mean, because that kind of denominator is really critical. I'm sure you've given this a lot of thought, but it seemed like you couldn't really get a lot of it just by looking at data that's reported to N3C, because you've got this denominator of patients who stayed home and got sick and got well and never showed up to the hospital.
Yeah, and that definitely got worse over time, the reporting, as at-home testing became prolific, and outpatient treatment options improved. I'm not aware of any good either statewide population resources like that have done surveys. I know that in our state, our rural communities are so strapped that they're barely hanging on at this point. So fulfilling, state requirements for reporting is the bare minimum that they can achieve.
You know whether NHANES, I don't really know much about NHANES, but I remember from various past lives there was a certain amount of NHANES involved, and right, that's a survey that I guess the CDC does of different diseases, and I wonder if they've added sort of historical data on COVID. Do you think they would?
I would think they would, and I know there's a delay in aggregating that information, so that might be something that future research can look at. But yeah, I'm not aware of any population level ones that we've come across yet. Good question.
No, interesting. Also, just one other, and if anybody else have questions, I don't want to hog the thing. Q&A. Okay, so we have, what are the contributing factors for health disparities between urban and rural? Anita Walden wants to know.
Yeah, I think that's the question of the hour. And there's a lot of problems answering that because there's not like one rural community. Rurality, as defined at in the context of what we're looking at here, is largely a function of population density. So it can be affluent, suburban areas that have low population density that might be outside of an urban center, or it can be frontier areas. So I think it largely depends on the part of the country you're looking at, what factors influence them. It could be the environmental factors related to water sources, or it could strictly be an access factor where if you live in Appalachia and you live 10 miles from the nearest health center, that could be a 2-hour drive because you have a mountain range in your way. And so it could be the literal physical barrier, or it could be lack of access to clean drinking water. It really just depends. And I think that's the problem, is that there's no definition of rural that meets even a fraction of the overall rural challenges.
Right, and then you have urban adjacent, which I was going to ask about, a similar issue, because I imagine defining that consistently would be difficult.
Yeah, we define that using RUCA codes, which are derived from census block tract information mapped to zip code. And it's basically a way to organize rurality based on commuting flows into urban centers. So that's how that distinction is made. So the urban adjacent rural is, rural areas by population densities that have large commuting flows into urban centers.
I see. Okay, that makes sense. All right, well, thank you. Great talk, very interesting. So on to our education group. Thank you. So Sean, are you taking this?
Thank you very much. Sure, I can take it. I'm going to share my screen, drive some slides here. Maybe. Sorry, technical difficulties. Wow, my browser is. Okay, now I can try and share my screen. Okay, can you see my screen okay?
Yeah, it looks very coastal.
Thank you.
I'd say it's not urban adjacent.
I think my computer thinks I still have another monitor attached, although I do not. There. All right. Sorry for the delay, everybody. So my name is Sean O'Neill, and I co-lead the Education and Training Domain team. Today, we're going to be talking about a project that's come out of the Education and Training Domain team, and it's been going on for well over a year now. We're calling this a sneak peek to the guide to N3C because it's not 100% complete yet. However, it is largely complete and very useful and readable. So we want to get the word out there. Today, we're going to be hearing from some folks on our editorial committee about the project, how it came to be, how to get involved, and where to find it. But first, I want to give a really big thank you to everyone who contributed. As with most N3C activities, it was a big project contributed to by a lot of different people, currently 37 authors from 24 different institutions, and that's really amazing. And it's just, as always, really heartwarming to see what this community can do together. So with that, I'm going to hand it over to Johanna.
Great, thanks. I'm Johanna Lumba. I'm an iThrive CTSA, the Director of Informatics there, and also the lead for the N3C Logic Liaisons. And I just want to start by saying that the work you're going to hear about today would not have been possible without Sean's leadership and incredibly hard work. And I think his people-first approach is evidenced by the fact that instead of tagging it on at the end, he opened this talk with acknowledging all the contributors. So, Sean, thank you. We love your style, and it's been a pleasure working with you. So most people on this call know that N3C is more than the data enclave that's depicted in this figure. It's also a research community that's dedicated to facilitating collaborations. And this has led to the rapid generation and dissemination of knowledge. It's helped inform our country during the COVID-19 pandemic. And the value of N3C is evidenced by the large number of publications and knowledge artifacts that the community has produced. We know that the creation of N3C required the development of novel processes and tools to support the data governance and the data sharing and the data analytics. And naturally, all of these tools have been rapidly evolving over the past 3 years based on requests from this really active community. Things look really different today in N3C than they did in 2020. And, that's a good thing. The new features have emerged continually, requiring Sean's a lot of work from Sean and the ongoing development of training materials. And in addition to those evolving tools and education, there's a set of foundational knowledge artifacts that's also grown. So now we're just kind of at the point where these tools and processes have matured, and we've had this opportunity to step back and pull together that vast amount of training content, the expertise and best practices, and put it all into a single guide. It is designed to be a really well-organized resource, and for both the new and existing research teams in N3C. And because it's covering all phases of the process, the guide should accelerate onboarding, support project planning, and enable teams to make the best use of that full suite of tools available. Even people who've been around for a while will really benefit from reading through it. I know I have myself. And having all that information in one place is also a good support for the regulatory processes and compliance. It's important to point out that the guide also incorporates good practices that are not specific to this particular platform and community. So we think, many people will benefit, but we do expect that our readership will be, diverse, just as these interdisciplinary teams we see working on Enclave are. We know that diversity is really what is necessary to do robust and ethical research with this data. So I'm going to hand it over to Karen.
Thanks, Johanna. Good afternoon. I'm Karen Crowley. It's my privilege to co-lead the education and training domain team alongside Sean. I make my home in the Brown Center for Biomedical Informatics at Brown University. Though N3C educational resources were in abundance, there was a need to pull them together into a pathway that researchers could follow, from engaging with N3C to conducting research within the enclave to publishing real-world evidence in the fight against COVID-19. This need for a pathway undoubtedly was discussed in many local research labs, but the ask was too great for any one isolated group. The education and training domain team was formed in small part to address this need. And the guide to N3C was discussed at the inaugural meeting. A short time later, an editorial committee had been formed, colleagues had been solicited for input, and a multitude of topics generated. This graphic is a screenshot of topic clusters, which became draft chapter outlines that were made available for N3C community feedback. The editorial committee reviewed every topic and comment. Some chapter outlines were augmented, some trimmed, and others found their way to new chapters. We resolved that this guide was to be researcher-centric. We also intended that this guide and the team science processes employed to create it would serve as a model for future such endeavors. And it was with these clear intentions that each decision was made and each step taken. Next slide. I introduce you to the Researcher's Guide to N3C. Your path to getting started with N3C is laid out in the first 5 chapters, including a model research story, a look at the N3C data lifecycle, a discussion of governance, and steps for onboarding. When you're ready to begin your research, follow the next 5 chapters where you'll learn how to gain and manage data access, find expert guidance in understanding and analyzing the data, and steps to publish and share your work. You'll also find a vital chapter on research best practices. Finally, you'll find the first 2 of what we hope to be many special topics chapters, help and support, and machine learning. I'll turn it over to Sharon.
Hello, I'm Sharon Patrick from the West Virginia Clinical and Translational Science Institute, and I work in the IDEA CTR network funded by the NIGMS. This evening, I'll be talking about the academic points and parts of the Researcher's Guide to N3C. And in particular, we're going to look at the chapter leads and contributors, the README points, the progress tracking, the review process, and iterating. So based on the work created on the topics from the brainstorming that Karen showed us, that's what we determined to include into the guide. So the editorial committee reached out to colleagues that are subject matter experts in each of the chapter title topics to be chapter leads. Through additional collaboration, the team found it beneficial to have chapter contributors. Contributors helped in many ways, from contributing content to having another set of eyes on the chapters. The README points So in order to have a consistent workflow, a README was created for the chapter leads and contributors to read before they started to write. In this document, writers can understand their role and expectation, the usage of the Google folders and subfolders, the guide outlined, and other references important to those contributing to the writing. This was a helpful resource since it's hard to meet with individual writers, so having the README was a helpful component of the guide. And thank you to our leads, Karen and Sean, and others who contributed to that document. So incorporated into the README was a reminder for reusing existing information. We wanted to utilize the information that was in place that the N3C administration and leadership, Palantir, and other key N3C staff and stakeholders have created. There's a lot of information on the N3C landing page website, including users' checklists and trainings. So a goal of the writers is to link to existing information. The use of the existing information helps to have a source of truth for those using the N3C. And also cross-referencing topics in other chapters to help the researchers find content was highly encouraged. A style guidance, we had loose guidance as each chapter was an individual process, and we expected each chapter to have a little bit of a different tone. The editorial committee and the education training domain team organized working writing sessions to get discussion and feedback from authors and chapter leads. We had guidance through a review process, which I'll mention here in a minute. So we had a progress tracking. We had a progress tracking sheet to monitor the status of the chapter that the leads would complete. We asked on a monthly basis. And key factors that we looked at were the percentage of completion, the word counts, and needs and blockers that the writers encountered. Throughout the process, if we noticed some chapters weren't being updated, we used this as an opportunity to nudge the chapter leads to maintain our goals and timelines. Then as the chapters reached completion, we had an editing and review process. Each chapter was assigned 3 editors to review the content in the chapters. Through this review, editors focused on content, grammar, and suggestions. And then the image there on the slide shows the progress tracking sheet that the team used to monitor the progress of the writing. So iterating, like most works in progress, and as the N3C has evolved, the Researcher's Guide to N3C will come in iterations. This is the first version, and we have chapters in the pipeline, as Karen had showed all the chapter titles, and we have additional special subjects to add to this guide. So overall, this will complete my portion of the presentation, focusing on those academic parts to the Researcher's Guide to N3C. And then we have Will up next to talk about the processes used to take the information from Google to the final versions.
Thanks. Sean, may I have the screen? Thanks. All right, so I'm Will Beasley from the University of Oklahoma, and here's some slides describing how the software was used to facilitate the collaboration and the rendering and the deployment. Working backwards, here's the book, the rendered book in the webpage. And here's one of my favorite chapters, which covers the enclave tools. It's one of my favorites because Amy and Andrea do a great job acting as a narrator, transversing the huge space, you know, from SQL to R to Python to concept sets to the knowledge store. And the chapter doesn't try to be like the definitive guide to everything. Instead, it provides a perspective of how these tools fit together, and then provides hyperlinks to the authoritative resources for anyone seeking detail. So here's the rendered version. And, you know, the plain, the source underneath it is Markdown. And to see that, you can click View Source, and you kind of see this pre-rendered, which kind of helps us, and the real Markdown is here. So how do we get from the real plain text Markdown to the rendered version? GitHub Actions. So GitHub Actions is a service within GitHub, and it listens for commits to the main branch. And when that happens, it will build, it'll spin up a Docker image that will build and deploy the rendered web page. And it uses Pandoc and Quarto, if anyone's familiar with those tools. They convert the Markdown into the pretty looking book. And let's see, so on this slide, for writing the chapters from scratch, Google Docs just, we weren't being unconventional or anything, it was just ideal for having, Sean, would you say 37 different authors working in parallel, typically 3 or 4 authors per chapter, and then the editors reviewing in parallel. It just worked well, and I'm not sure, there's no reason to change it or have anyone learn a new tool. But to get from the Google Docs to Markdown, we used this Chrome extension, G2MD. And it did a decent job translating. For the text itself, excellent job. But as you can see, all the cross-references and images, the book has a lot of cross-references and images. That took a lot of manual work. And I'm not sure there's any tool that can do it. It really took effort. And I think we're proud, and we wanted to have all those good cross-references jumping between chapters, so people wouldn't have to read sequentially through the chapters and through each section, and also linking to other figures and outside resources. And the translation from Google Docs to Markdown happened only once per chapter, once all the authors said they were done and the 3 editors had signed off. And it's about 2 to 4 hours per chapter after the editors were done. And that sounds like a lot of time, but I think it's trivial when the content is as good as what the authors did. I mean, that writing the material is a lot more difficult and time intensive. So once the Markdown is produced, the pipeline proceeds as it did as we described here, with the Docker image being spun up. So now let's say you have, you go to the rendered, wherever I moved it. Let's say you do go to the chapter and you want to make an edit. Well, all right, let me back up. Let's say you see a new chapter that you just feel needs to be written. If that happens, please come to the editorial committee. If approved, we'll set you up probably with a Google Docs and the same process. However, if you're reading it and you see oh, you know what, this just needs a paragraph here to clarify, or, this has changed since blah, 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 whether it's a new link or something. In that case, we chose kind of this tool set because it was easy for people like you to make edits. You're looking at the rendered version, click edit this page, and it's going to take you to the raw Markdown. And Markdown, if you've never used it, it's pretty simple. For the kind of just quick editing, you'll learn it within minutes. Find where you want to make edits to the code. And then that will create your own copy. In the Git terminology, that's a fork. So you're going to commit that change to your fork, and then go to, and then create a pull request, and basically asking us, the editors, to accept your changes into the main branch. When that happens, the new Docker image is spun up. Once it's approved, the new Docker image is spun up. Everything gets stitched together, rendered as HTML, and then deployed publicly. And Ken.
Yeah.
Will, my computer's being a little bit wonky. Would you mind continue sharing, Will?
Sure.
That'd be great. Thanks. So on to the next. Yeah, thanks, Will. The next slide. Basically, you left off at the right perfect point after that demo, where people who suggest there's other things that could be added in, that's right in the spirit of how this came together. It basically spawned out of everyone in this community, and it's a very collaborative community, considering how would I have helped my past self plus my collaborators, because it takes people from all different disciplines to work together on a project. Navigate all the paths possible within N3C for my projects, my goals, and then how best can I get help to those after me to find shorter, more effective paths. So you will be doing that if you click on that edit portion there. And And, it's not listed here, but, you want to have this as an open question that you ask yourself when you realize this is what I got from the guide to N3C. Here's how it helped me. Here's how it can help other ones. So this question's open. This first version will evolve into revisions from feedback from all of you in the community. So you can do that by joining the education and training domain team calls. The link there goes to the actual call registration. There's a Slack channel. There's also ways to email any one of us, or as Will was showing, you can edit it right in that rendered page that takes you to the GitHub and the underlying markdown, or post an issue if that's what you prefer in GitHub. Anyway, either way you do it, you have the URL right here, which is also linked within these slides. And the idea is to get feedback from you on how this is more effective and really get into how each of us can learn so many more things from one another, and also not reinvent the wheel. If there's things that people have done, if there's certain concepts that you've dealt with, and you could go to office hours and get help from data liaisons. You could work with logic liaisons to build up pipelines to, build up phenotypes and cohorts that you're going to go and analyze. But this will walk you through a lot of that and have you much better informed for when you go and seek the help, or maybe enough that you do it on your own. And then you may have ideas on how to bring that back and improve the guide. So that's what we want to look at here, and be really thankful for all this, not just the people pictured here on the editorial board, but all the contributors to the guide to N3C and all of you collaborators out there in the network. You could see it here in the snapshots of the dashboard at CD2H, N3C's dashboard. It shows the institutions by relative size of number of collaborators and type by color and over the US map. But you also see these data use request project areas and these blue dots with all the individuals who are, with their given affiliation tied into that. You can visualize that and see those of us who've worked with you, or we can see where you've been and where you can add in yourself into other domain teams as well. So it's going to arise organically how to improve this. Going to the next slide, it might go to some other topics here. And this is just a set of projected topics. We already have one. Big thanks to our CD2H program managers who are setting up all these guide to N3C talks that will look at evaluating machine learning models and best practices, touching upon one of our special topics that's yet to come, as well as our analysis tools and all the reusable artifacts that come from folks like the logic liaisons that Johanna leads, a lot of the training materials that have been co-developed by a lot of the members of this team and the education domain training team. And I would say, things that have yet been shaken out as far as issues, like it was just last week that there was a Medicaid privacy preserving record linkage training system on how to bring in those Medicaid claims. So that Sean and others had led. So we'll try and bring those into these later examples. Like in the fall, you can look at how to stress test your design analysis assumptions with health equity in mind. And there's a new tool within the Enclave called Protocol Packet to help you organize your process for design and carrying out analyses. And maybe we'll get in early winter to a new special topic chapter, which the editorial board has been planning for a long time, a start to finish example with multiple privacy preserving record linkage enabled data. So we'll see how that goes. We do have a call out. If you do join that education and training domain team Slack, you'll see there's a call out for other chapter leads and chapter contributors to do some more N3C community examples. We'll dive in depth to some of the things you would see now in Guide to N3C. And with that, I want to again thank the rest of this amazing team who always learn things from and take any questions. Thanks, Will, for steering.
Questions? So that was great. It's quite an effort. Let's see. I think okay, David Sarner, enormous thank you to all who helped bring the guide N3C to fruition. Absolutely, that's a huge effort, very valuable. Community in the world will be grateful. I have to dash for another call now.
Yeah.
Well, I think David speaks for all of us. Any other?
One of the things that Sean nicely brought up in the chat that I didn't bring up is, how besides the portion of how you want to do some edits as a user and give feedback to the current guide, there will be sessions on how to contribute further to the guide in N3C. You want to talk a bit more about that, Sean?
Not necessarily, just to note that not everyone is super familiar with the GitHub workflow that would be used for larger contributions, or even how to submit an issue to a GitHub repo. So we'll be doing a little bit of demo on that, so people can make sure that they can contribute.
Great.
Great. So, but it's a living document, which will continue to grow. All right. Well, thanks. This was very inspiring, and we'll see everybody in a couple of weeks. Take care.
Thanks.